Hi everyone, thanks for joining. We'll be starting the webinar in just a minute. Okay, I think we'll get started. Hi all, and a very happy new year to all our guests joining us for our first webinar of the year. A very warm welcome from the Australian National University here in Canberra, and welcome also to this special feature webinar where we'll be asking questions from medical students to our two esteemed guests on the topic of the COVID-19 Omicron outbreak. I'd firstly like to acknowledge the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located and from where we are broadcasting to you today. And I pay my respects to their elders past, present and emerging, and also extend my welcome to any Aboriginal or Torres Strait Islander attendees here with us this evening. So introductions first, I'm Bridget. I'm a medical student and a volunteer for the ANU COVID-19 Peer Support Program. And exciting to be hosting this webinar alongside my colleague Evangeline, who is a fellow medical student. And we are joined also by our program lead, Dr. Dipti Talalika. So before I introduce our two speakers for today, just a couple of housekeeping notes. We ask all attendees to keep their video and microphone switched off, but if time permits, we encourage attendees to ask questions by using the Q&A button that you will see towards the bottom of your screen. A feedback poll will pop up on your screen, and toward the end of the webinar, we welcome your feedback and all responses will be anonymous. And if you have any technical issues or questions after the talk at all, please feel free to email international.health@anu.edu.au and we will try to assist you where we can. And finally, please just take note that this forum is being recorded. So today's webinar will be delivered by Associate Professor Sanjaya Senanayake from the Australian National University and Professor Neeraj Nischal from the All India Institute of Medical Sciences. We are incredibly honoured to have you both here with us as infectious disease experts to answer some questions posted by medical students around the emergence of Omicron variant and to engage in some discussions on the Australian and Indian perspective to this variant in terms of presentation, management, vaccinations and broader public health issues. So welcome to both of you. We have Dr. Neeraj Nischal, is an Associate Professor in Medicine at the All India Institute of Medical Sciences in New Delhi in India. He has a special interest in infectious diseases and has been at the forefront of COVID patient management and resource development for the country since the start of the pandemic. So welcome, Neeraj. We have Dr. Sanjaya Senanayake, who is an infectious diseases physician in Canberra. He is an Associate Professor of Medicine at the Australian National University and Director of the Department of Infectious Diseases at Canberra Health Services. Dr. Sanjaya has a strong interest in infections of public health importance. He has been a regular presence in the media during the pandemic. So welcome, Sanjaya. So with this introductions out of the way, let's begin with the webinar itself. And I'll kick us off with a question about the infamous virus and ask you both if you can provide a background to the COVID caseload and genomic variants at play in your respective communities since the pandemic began, and if you could particularly take note of with reference to the emergence of the Omicron variant.
Yeah. Neeraj, I'm happy for you to take the lead.
Yeah, sure. Thank you, Dr. Sanjay. It's really fascinating. The million-dollar question has always been, Vicky, what was the actually origin of this virus? It's something which everybody wants to know, but nobody has a definitive answer. So how many variants have actually circulated before everything started happening, on how many of the variants were not selected? It's really difficult to comment. But yes, over last 2 years, since this pandemic stuck, at least in our country, in India, so the majority of the variants, which we had 3 major variants. Of course, the first wave was driven predominantly by alpha and beta. And the second wave, which was, I will say, the most devastating of all the waves which saw over last 2 years, was Delta wave, dominated wave, which was very severe. And then, of course, this Omicron variant, which started somewhere in the last week of December in our country. And what the pattern we are seeing is now it seems that we have crossed that peak and now things are coming down. The way it got up, the caseload is coming down that fast also. And the best part was this time, whatever with the reason, of course, there are multiple theories floating around, but the cases, the severity of the cases was very, I mean, we'll say it was very mild type of thing. Of course, some people may argue that using the term flu-like symptom may be too early to say, but at least in my clinical practice, the cases which I saw over last 4 or 5 weeks, the cases were nothing more than the flu-like symptoms. I hardly saw any patient getting sick because of the COVID-19. Of course, we lost patients during this period, but in fact, all of them had some terminal illness, something situation where we could not have salvaged them with, even if they didn't have COVID. That was the situation. So if we see, the second wave was the most, I will say, difficult part of this whole pandemic so far, where we lost lives because of the seriousness of the illness. During first wave, majority we could save. There were casualty, of course, but they were in the highly susceptible groups. And with Omicron variants, luckily, the situation was much better, and we have been able to save majority of them. In fact, most of them did not require any specific care. Most of them recovered in home isolation, and that was the best part. So looking by this pattern, of course, it's following any infectious disease pandemic which we have seen in past. And that way, we hope that this is the beginning of end of pandemic, and with time, we will see that, okay, this is part and parcel of our life, and we should ignore this particular infection in our community. Yeah, Dr. Sanjaya.
Thank you, Neeraj. Yes, so it's very interesting. India has had has had a certain pattern of infections. Another country will have been slightly different. South Africa, for instance, has had 4 waves of infection. Australia, it's been slightly different. We had the initial sort of Wuhan strain, the D6, and then the D614G, which dominated sort of a lot of 2020 and was responsible for that big outbreak in Melbourne or Victoria in 2020. So that really was the hallmark of Australia's COVID outbreak in 2020. What happened in Victoria, that accounted for, the vast majority of cases and the vast majority of deaths in the second half of 2020. Then we had smatterings of Alpha, what used to be called the UK strain, as we sort of headed into 2021. But then Delta emerged. And Delta in the early second half of last year caused a lot of cases, and it was associated with a lot of hospitalizations, particularly in Sydney and Melbourne. Here where I am in Canberra, it was also an issue, but not to the extent it was there. And we were seeing about, between 5 and 10% of cases getting hospitalized. So that was very, very difficult. And I think Delta put a lot of strain on health systems all over the world. Then, of course, Omicron appeared in South Africa, or that's where we first heard about it in sort of late November. And we've been having an Omicron wave here. And thankfully, in the last sort of 2 weeks, we've seen what we believe is a peak. And while the cases haven't certainly returned to anywhere close to normal or close to zero, we are still seeing a plateauing of cases, a plateauing of hospital admissions, and numbers starting to fall. But of course, because we're not seeing a peak and then going to zero in 24 hours, it still means healthcare workers in many parts of Australia will be very stressed, tired, exhausted because of ongoing care for lots of COVID patients. I don't know if you all remember, in 2020, when the outbreak first started, our chief medical officer and deputy chief medical officers put up graphs, and they used that as a justification for why they were bringing in restrictions. And the two graphs were, this is what will happen if we don't have restrictions. We'll have a big, quick peak of cases, which will end rapidly, but that peak will be so overwhelming, the hospital systems won't be able to cope, and a lot of people will die. But if we put restrictions in place, lockdowns, etc., we'll see a slower increase and peaking of cases and then a more gradual resolution. So the outbreak will take longer, but it will have less of an impact on the hospital system. In many ways, Omicron represents that former peak, the rapid rise and fall, what everyone was trying to avoid in 2020. But the saving grace of Omicron has been, as Dr. Neeraj was saying, is that it is not so severe. So the vast majority of the cases were not getting hospitalized. So if 5% of Delta cases were ending up in hospital, less than 1% of Omicron cases were. And it's probably much, much less than 1%, but it's just because with Omicron, we haven't been able to calculate all the cases in the community. Of the cases we know it's about 1% or less, but it's probably a lot less. And I should also add that the fact that Omicron has ended up being much less severe than Delta, that is pure luck. We're lucky it ended up that way. We could have ended up with a more infectious variant, which was just as deadly as Delta, then we all would have been in a lot of trouble.
Definitely can agree with you. We got very lucky there, didn't we? I wonder if I can follow on the topic of Omicron and ask you, Dr. Sanjaya, how you think this variant evolved. And you've talked about the peaks, but what do you think is its life course?
Yeah, so in terms of where it began, we don't quite know. So it's important to realize that Omicron isn't Delta's daughter or Delta's son. It's certainly not the progeny of Delta. Just looking at it, we suspect that it may have been under the radar for a long time. So it may have been there around 2020, or maybe its ancestors were there in 2020, quietly circulating. And the reasons these variants evolved, there are probably three reasons we think about. The first one is that an immunocompromised person, so someone with a reduced immune system due to medications or due to an intrinsic disease of their immune system, gets the virus. And we know from case reports of COVID-19 patients who are immunosuppressed that some of them can continue to excrete the virus for up to 4 months. Now you compare that to a healthy person, an immunocompetent person who gets COVID, usually within sort of 2-3 weeks after getting COVID, they often won't have any meaningful detection of virus. But immunocompromised people can keep shedding that virus for up to 4 months. Now, they won't be getting sick. So the virus has got a healthy host in the sense they won't get sick, where the virus can replicate and replicate and replicate. And from one immunocompromised person, one of these variants of concern could have arisen. And that is why it's so important to make sure we protect our immunocompromised population from COVID, not just for their own sake, because we don't want them to get really sick, but we also don't want them to become the reservoir for a new variant of concern like Omicron. The other possibility is that Omicron has come from the animal kingdom. And I just might spend a couple of minutes talking about that. We think all coronaviruses, there are 4 that cause about 20% of the common colds in humans. There's MERS, there's SARS, and now, of course, COVID-19. We think they've all come from the animal kingdom and adapted to human beings. But we have found during this COVID-19 outbreak that the SARS-CoV-2 virus that causes COVID-19 can go back from humans into animals. So we've seen domestic dogs, we've seen domestic cats, we've seen animals in the zoo, wild cats like tigers in the Bronx Zoo in New York, get COVID and actually get sick with it, not desperately sick, but get sick with it. And we've seen transmission to other animals. And on one occasion, we've seen COVID-19 go from the animal kingdom back to humans. That was with mink. So you've all heard of mink coats and mink furs, etc. Well, the mink farms in Europe, in Denmark, they saw transmission from humans to mink back to humans. And the concern there is about that is that when the virus goes into an animal and tries to get into its cells, it has to negotiate that animal's ACE2 receptor, which is going to be different to a human's ACE2 receptor. So to negotiate that, it has to change and mutate. And therefore, if it comes back to the human, it might be far more changed and mutated than it was before it made the jump from human to animal. So Omicron could have come from there. We've done, or studies being done, looking at the ACE2 receptors of various mammals, and we've found that COVID-19 is compatible, or the virus is compatible with infecting various animals with certain ACE2 receptors. And look, the final way that Omicron could have sneaked under the radar is if it's been circulating in developing countries which have got poor surveillance systems. So it may, if it had been Australia or the UK or the US, it may have been picked up earlier because of very good surveillance systems, but in countries with poor resources, they just didn't have the capacity. And it could have circulated and slowly but surely mutated and transformed into Omicron.
Thanks, Dr. Sanjaya. I wonder if I could ask on the topic of the opportunity of the virus to replicate many times. So Dr. Neeraj, did you want to add something as well?
Yeah, so the third possibility, in fact, this is my favorite punchline, that this Darwinian theory of survival of the fittest, that is something which is part and parcel of all living organism on this planet. And that is what this virus is trying to do. So we all knew this virus ultimately will become part and parcel of our life. That is something, because pandemic of this nature cannot go away overnight. And virus also realizes that it cannot survive outside a living host. So that it's important for it to adapt in a way where it can infect people without causing much problem. And that is where I want to believe that Omicron is that missing piece of puzzle, where now this virus is trying to survive, coexist with humans. So it was very infectious, no doubt about that. The attack rate was much, much higher than what it was seen with the previous variant. But surprisingly, whether it was because of the previous infection, the immunization program, it was not troubling the host the way the previous versions did, especially the Delta variant. And that's why we believe, as Dr. Sanjaya rightly said, this could be circulating among this thing, because like I said in the start, there could be variants which were not picked because they were not variant of concern or something, they were not causing problems. And just think of the number of hosts it had across the globe where this virus is multiplying. I'm not just talking about the immunocompromised patients. I am talking about the general population at last. So billions of people have been affected by this. So if you look from that angle, the number of times this virus is replicated, and it doesn't have any proofreading system, the chances of mutation accumulating in these viruses will always be there as long as it's multiplying. And that's why we have always said, even if you are vaccinated, you have to follow COVID appropriate behavior, because you cannot allow this virus to replicate inside you. Because if it replicates, there is always a possibility that it's going to mutate, and it could become more dangerous. It could become less severe. So whatever is going to give its advantage for its survival, of course, that is going to get selected. So this Delta variant, predominated over the previous version because it was more infectious. But at the same time, it was causing more immune dysregulation, more of severe pneumonia type of picture because of that property. So ultimately, that is being replaced by Omicron because it is more infectious, but at the same time, it's not killing its host. So with time, of course, Omicron is not the last variant, that's for sure. We will see more infectious variant and hopefully milder and milder forms, just like we see seasonal flu, because after all, influenza started like this only. First wave was there, then second wave was more deadly than the first wave. Third wave, things started improving and subsequent mild waves did come. And after that, things become a natural part of human life. So again, this particular thing is going the same way. And hopefully whatever will be selected in future maybe it's more infectious, but at the same time, it's not going to cause more harm to the this thing. So Omicron could have gone under radar. It has accumulated lots of mutation, and now it has got a selective advantage over the previous version, and that's why it has started predominating in various parts of the world, and that's what we are seeing.
Thank you. And while you were just talking, I received a question, which is what are the chances that we will see newer variants? But I think you've answered that question, that we are going to see newer variants. But perhaps could you comment on how confident we can be that at this moment during this outbreak, is Omicron variant the predominant variant that we're seeing in our community and likewise in our hospitals?
Yeah, so whole genomic sequencing so far is showing that, certainly with hospitalizations and community cases, we're basically seeing Omicron. So we've got whole genomic sequencing to show that that is now the dominant variant that we're seeing. That doesn't mean we're not seeing the odd Delta case. And certainly in the hospital setting, a couple of weeks ago when I was on, I saw a very young person come straight to emergency and go straight to intensive care because they were compromised from a respiratory point of view by their COVID illness. And it happened very rapidly. I think they'd had 2 doses of vaccine as well. So I thought clinically this looks more like a Delta patient than an Omicron patient. And yeah, they ended up having Delta. So there are other variants out there. And probably it is worth touching on how we tell apart the different variants during this Omicron outbreak. Now, whole genomic sequencing is something that will definitively tell you this is Omicron or this is Delta. And you can be very confident of that result. And actually here in Canberra in our lab, in 24 hours, you can get that result if you do whole genomic sequencing. But not everyone can do that. And certainly a lot of people have been using the PCR tests and looking for something called an S gene dropout when they've been looking for Omicron. So the virus SARS-CoV-2 has got a number of genes, and the alpha version or the alpha variant and Omicron, the S gene doesn't come up positive when you test for it. Doesn't mean it doesn't have an S gene, but it just doesn't come up positive. Whereas with most Delta cases, the vast majority, you will see the S gene positivity in a test. So a lot of people have been saying, okay, if we see an S gene dropout, it's Omicron, and if there's an S gene present, it's probably Delta. The reason I also mentioned that is that there's a curveball. There's now the progeny of Omicron, the BA.2 that people may have heard about, which is sort of a variant or subvariant of Omicron, and maybe even more infectious than Omicron, and has been found in over 55 countries in the world, including in Australia. Even though it's a variant of Omicron, it doesn't have that S gene dropout. So some of the cases we might have been calling Delta without doing whole genomic sequencing might have also been this BA.2, the child of Omicron.
Okay, so as well as testing and sequencing, clinically, is there a way that we can look at a patient's symptoms and identify, yes, this is Omicron, or yes, this is Delta?
Neeraj, would you like to answer that? Or?
Yeah, so you have briefly mentioned that one of your patients had a severe respiratory distress right at the start of the illness, and he had to be wheeled to ICU. So over last 5 weeks, I have seen just one sick patient, and the genome sequencing actually showed that he had Delta variant. So clinically, I mean, symptoms may be same, but if your patient is deteriorating very rapidly in spite of being vaccinated and everything, then you may think of that this patient may actually have Delta variant. So again, differentiating as a clinician doesn't matter to me, to be very frank, because here, anyway, most of us are vaccinated. So the use of monoclonal antibody, the type which we have at the moment with us, that is not effective against Omicron. And those who are vaccinated, we hardly use these monoclonal antibodies in them. So treatment-wise, the option remains the same. So we are not too much worried what variant actually the patient may have. But yes, clinically, if the patient has deteriorated very rapidly, the CT or X-ray is suggestive of rapidly progressive GGOs and a patient lining up into ARDS, then of course the suspicion should be high. So these are the subtle, basically subtle things which we look for, but overall management is not going to change. So we don't put too much stress whether it's Omicron or Delta. We treat according to the patient's need.
And I might, thank you, Neeraj. I completely agree with that. And what I would just also add, if you want to look at any differences, the UK, one of the Health Security Agency papers came out recently, and they tried to work out the differences between Delta and Omicron. And basically the mild Delta and the mild Omicron case in a vaccinated person will look very similar, but two things which they found were slightly different is that you're much more likely to have a sore throat with Omicron than Delta. You're much less likely to have a loss of taste and smell with Omicron than with Delta. So they're the two big differences. But that, of course, doesn't mean you can't get both those symptoms with either variant. But that's just a slight difference that they've picked up in the UK.
Thanks to both of you for your answers to that question. I'm wondering, following on clinically, is it possible to present with long COVID after an infection from Omicron, and what might this look like? Or is there a difference with long COVID between genetic variants?
So before we go to that, can we talk about the symptoms? Because I have a couple of slides to show just to differentiate, as Dr. Sanjaya just said. So I had kept it for further discussion, but since we are talking about that, let's finish with that. So I will just share my slide. This is based on the basically the observation which we have made over last 3-4 weeks, and it's based on that. So I'll just quickly go through that. Just a second. So is my slide visible?
Yes, it is. Thank you.
So here what we saw that, of course, Dr. Sanjaya said, yeah, sore throat is something which we are seeing very commonly with Omicron, and this sore throat is so tough for the patient. They find things, it's really difficult for them to swallow things. So that is one complaint which patients have been making quite commonly, and this sore throat may actually persist for 7 to 10 days even. So if somebody has presented with severe sore throat in current scenario, that one can think of Omicron, but of course it can happen with other conditions as well. So we have to be very careful. Tiredness, headaches, and aches and pains, again, especially lower backache. That is something which patients are complaining this time, which was not that much severe as in previous waves. So these 4 signs, of course, we are seeing quite common in our patient with Omicron. Apart from that, of course, chills, the fever, even if low grade, the patients are complaining of chills. They have night sweats, and many of them are complaining of burning eyes. So these are subtle signs that, okay, these patients may actually have Omicron variant as compared to other variants. So just to summarize, the loss of taste and smell was more common in Delta variant, and surprisingly, this was our observation, that those who developed loss of taste or smell did better than those who did not have this symptom. So if patient complained, okay, I have loss of taste or smell, we could counsel them, okay, you can stay at home in all probability, you are not going to have any severe complication. And most of the time, it happened that way. So And diarrhea was again a very common finding in patient with Delta variant. There could be other reasons for that diarrhea, because in our country, of course, the treatment was, it was more patient driven. They used to take all sort of medication without consulting a doctor. So that could also have played a part. But of course, this Delta variant had a lot of patients presenting with diarrhea and other GI symptoms. And Omicron, like I said, sore throat, aches and pains were more common, along with night sweats, burning eye, nausea, appetite loss. Again, these patients after recovery are complaining of appetite loss. That is something which we are seeing quite commonly. So you can say this is one post-COVID complication which we are seeing. But since we are just in 4th, 5th week of Omicron wave, so what will be the long-term complication of this? We are not sure yet. So this is something we have to look into. So yeah, we can go ahead with further discussion. If Dr. Sanjay has to add something to this.
No. I think that was very interesting, particularly people doing better if they have the loss of taste and smell.
That was observation. I'm not saying I may be correct, because it was not this thing, but yeah, this was a common observation in our patients.
Yeah, so that was very interesting, actually. I might even ask to borrow that slide later if I can.
Sure, I will.
Thank you very much. I guess going on to the original question about long COVID as well, the first thing I would say is this: we now have a World Health Organization definition of long COVID. So that was very good. I think there were a lot of people who were suffering with what they thought was long COVID, who felt that they were not being recognized as having a serious medical complaint. But now the World Health Organization have talked about the post-COVID-19 condition. It's usually 3 months from the onset of COVID, and they're usually symptoms that last for at least 2 months. And you've all heard of the various symptoms. People get clouded consciousness, brain fog, fatigue, aches and pains, feeling short of breath. So a wide variety of symptoms, a constellation of symptoms. So regarding Omicron, look, Omicron only really came to the fore in late November. So in all honesty, I think it's too early to say whether Omicron is associated with a post-COVID-19 syndrome or a long COVID syndrome. So it's too early to say that. We certainly know that all the other variants have been associated with it. We also, in terms of do vaccines make a difference, we've got varying data on that. There's some data saying if you're vaccinated with 2 doses of a vaccine, this is prior to Omicron, of course, your chance of getting long COVID is reduced by 50%. But there are other studies which say that vaccines may not really affect the course of your COVID illness, apart from reducing the chance of you getting COVID. And I guess more and more research is evolving about why people are getting long COVID. And some of the reasons are in South Africa. I can't remember which university it was, may have been Johannesburg, I think. But in South Africa, they found that people with COVID had a lot of microclots. So not large pulmonary emboli that you can find on a CT scan, but microclots that can't be detected easily via a blood test or via imaging. Here in Australia, we found, I think it was in Sydney, which institute? I can't remember which institute in Sydney, but they found that people with long COVID tended to have higher levels of a molecule called interferon. Interferon is a part of our immune system, and it also in the past used to be used to treat infections like hepatitis C. And we always knew that one of the problems with interferon was if you were getting treatment with it for hepatitis C, you could feel very tired, you could feel very low, you could get depressed. And that fits with a lot of features we see with long COVID. And so the Sydney group did find high levels of interferon. There's also been associations with diabetes and people who've had more severe COVID. And in some UK data, females more than males seem to get it. So we're learning a lot about long COVID. Definitely happens with all the earlier variants that we've seen. Might happen with Omicron, too early to say. and vaccines may or may not make a difference.
Thanks to both of you. Dr. Neeraj, did you have anything more you wanted to say about long COVID or symptoms before I move on? Because Dr. Sanjaya has touched on vaccines, so I do really want to ask him.
Yeah, so again, long COVID syndrome is something, I mean, it's real, but at the same time, how to deal with this, that is something which we are still learning. So all we actually suggest our patient to give it time and show some patience. I know people will say, okay, you are not trying to understand that we are facing this problem. But they have to understand that as a doctor, we have limitations. We cannot treat everything. Sometimes time is the biggest healer. That's what I like to tell my patients. And you'll have to give time. If you have some issues, of course, you need to consult a doctor. But majority of time, the doctors will say you'll have to give it time. And with time, you are going to improve. But of course, you have some residual end organ damage because of COVID-19 that will require proper rehabilitation. The role of peer support group, especially those who are facing psychological issues, the nightmares, basically their ability to concentrate is very poor. In fact, even when I had COVID way back in October 2020, for next 2-3 months, I used to forget names, and sometimes I feel I still do that. So whether it's a psychological or it's a long-term effect of COVID-19, it's really difficult to pinpoint. But we have to find a way to, when none of them are usually life-threatening. As long as it's not life-threatening, it's not affecting your day-to-day activity to the state that, of course, you are just lying in bed or something, then I think you'll have to give time, talk to your peers, consult a doctor whenever you need, and with time, you will definitely improve.
That's great. So thank you. Let's move on to a question that I think is on everyone's mind regarding vaccinations. And perhaps Dr. Neeraj will start you off. So a lot of people have had the COVID-19 virus, specifically the Omicron infection, before they were due to get their boosters. So in those patients, would you still recommend them to get their boosters? And if so, why?
So again, Professor Sanjaya very pointed that in developing countries, the virus are replicating. We don't have surveillance system to pick up the variants. So most of developed countries are talking about booster and second booster and third booster. But what they fail to understand, that no one is safe till everyone is safe. This is something which I have borrowed from WHO director's speech. So they have to realize that boosting their population alone is not going to help, because if this virus is replicating somewhere in underdeveloped, under-resourced countries, there can always be a variant, more difficult variant, which can bypass all these immune response generated by vaccines and cause more havoc. So if you ask me, somebody has got infected, has taken vaccine, 2 doses of vaccine, even 1 booster. Now, the countries should focus on providing these vaccines to those countries which don't have this facility yet. Because in today's world, means of transportation is so fast that even 1 case from any remote part of the world, if lands in your country, that can create havoc. So if you personally ask me, I'm not very big fan of keep on boosting the population at the same time forgetting about the rest of the world. We have to remember this is a global pandemic. Unless we deal it globally, unless we create a global herd immunity, no one is safe. And this is what I will say. So, I mean, of course, wherever possible, take your booster. You may feel that you are safe, but as long as this virus is replicating in any part of the world, you are not safe. And that is each one of us have to understand.
Yeah, I think that's a very good and important reminder that we need to consider distributing to other countries that might not have quick access to those vaccines. I have a follow-up question for you, Dr. Sanjaya. So we know that Australia has one of the highest rates of vaccination, both the first vaccine as well as booster, at least the second shot. And of course, in the last 2 months, we have seen case numbers rise significantly. So what does that say about the performance of our vaccines? And do you recommend people getting the 4th shot, given that that has been announced recently in the news?
Sure. Look, Evangeline, I'll answer that circuitously. I guess, in fact, when Omicron came out and we heard that South Africa was the country of origin, although that was the country where it was recognized, it may well not have been the country of origin. It could have been somewhere in Europe. In a sense, obviously, I was horrified at many levels, but at another sense, agreeing with Dr. Neeraj, I thought, here is an opportunity. Here is an opportunity for the world to realize that if we just concentrate on our own backyards only and forget about the rest of the world, in particular the developing world, all that will happen is some variants will occur in countries with low vaccination rates and lead to new variants of concern arising. And in fact, recently there's been another variant that's been called IHU, which caused only about a dozen cases in France. And that was in November, I think it came out, and it hasn't taken hold since, thankfully. But they think it probably came from Cameroon. And around that time, only 2.5% of the population in Cameroon was vaccinated. And I can't tell you if that was with 1 dose or 2 doses. So again, following up on Dr. Neeraj's point, it's so important that we have global vaccine equity. Now, unfortunately, the problem with my hope that everyone would now see that this would mean in the developed world that we'd have to concentrate on the developing world, the problem was that it turned out that Omicron was so good at evading the immune system, it was also very good at evading vaccines, and that the only way to protect ourselves against getting Omicron, getting symptomatic disease, was to get a booster. So if you look at the UK data, after 2 doses of Pfizer or Moderna vaccines, the vaccine efficacy against symptomatic disease, so not hospitalization, but just symptomatic disease, so getting COVID, a sore throat or a fever, etc. After 20 weeks, it was only about 10%, which sounds pretty low, but with 2 doses of AstraZeneca, more than 20 weeks later, it was pretty much 0. Now, the protection against hospitalization still wasn't bad. The vaccine effectiveness of that was about 44%, less than against Delta, but still pretty good. You sort of reduced your chance of going to hospital by almost 50%. But we have found that with a booster, it does improve your chances against Omicron. So your vaccine effectiveness rise against hospitalization goes up to 83%, 10 or more weeks after your booster. And even against symptomatic disease, it's about 65 to 75%, 2 to 4 weeks after the booster. But it does drop to about 45 to 50%, 10 weeks after the booster. And I wouldn't be surprised if at 20 weeks, it's much lower again. In terms of why should someone get a booster, particularly if they've had COVID, we've got data showing that infection and immunization provides better immunity than from infection alone. And as Dr. Neeraj was saying, how many more boosters do we have to keep taking? Well, we probably will need regular boosters, but hopefully not so frequently. Because if we're having to have boosters every 3 months, every 4 months, every 6 months, there's also a chance that we might start to see hyper-responsiveness, and our immune system might not respond so well to the latest booster. The antibody levels, the T cell responses, etc., may not be so good.
Great, that was really, really detailed response. Thank you for that. So going back to Omicron, we touched on how there are less, Omicron is a lot milder than your Delta and other variants. So in terms of treatment options, we'll start off with Dr. Neeraj. What are some treatment options available in your center when someone is infected with Omicron and requires hospitalization?
So again, the treatment of the various variants have, I will say it's still an enigma. I know there are a lot of research papers which claim that one particular treatment is better than the other, or it's going to, of course, one drug which was recently launched in our country and touted as game changer, that is molnupiravir. So we have number of antivirus, so-called antivirus available in our country. But in personal experience, none of them actually showed any difference in the outcome of the patients. So our strategy had been very simple. See, there were three types of patients to us. One who were just mild asymptomatic type. Of course, all we need to do was to treat them symptomatically for whatever symptoms they had. Keep a close observation, especially in the vulnerable groups, and hope they will recover with that. Most of them did that way. And then there were a group of patients who presented to us in moderate category. And third one was severe category. So what we realized that those who landed up in severe category, majority of them we were not able to save. So it depended on when did we pick the patient. In previous two versions, I'm talking about the previous two waves. So those who were picked while progressing from mild to moderate, we were able to save majority of them. We hardly lost any patient, but those who presented in late complications, we were not able to save them. So the three things which actually helped in such patients were institution of oxygen at right time, role of steroid, and anticoagulation. These three things helped us in saving lives. Apart from that, whether you are talking about remdesivir, the plasma therapy, anything, most of them never worked in these patients, even if they presented in mild course of disease. So picking up the right patient and instituting right treatment at right time, that was the key in managing these patients. And so far, what we did was to prevent those complications from happening. So again, the role of steroid, that was very important. But when used at right time in right doses, that was again important. If you use it too early or you leave it for too late, it's not going to work. The same way for anticoagulation. Of course, those patients who required hospitalization, required oxygen and steroid, they were the candidates which did well with anticoagulation. So over the last 2 years of treating these patients, I have realized the right drug at right time. So in this particular case, the drugs preventing the complications from happening or progressing, that is steroid, oxygen, and anticoagulation, helped in saving life. Apart from that, everything else more or less worked as placebo, nothing more than that, satisfying a patient that, okay, we are doing something. But in reality, they were not doing any good to the patient. I know people will say, okay, show me your data. Where is that data? But whatever data has been published, if you see it properly, you will realize all the antivirals that have been touted so far, most of them have not worked in a real world scenario. It may have shown some effect in clinical trials, but when it comes in real world, so there is always a gap between the evidence which is published and clinical scenario in real world. And what we realized that three things which saved life was these three things when we instituted it in appropriate patient at appropriate time. So nothing different in Omicron. Luckily, Omicron patient, none of my patients required any of these therapy, whether it's oxygen, steroid, or anticoagulation, because most of them were asymptomatic or mildly symptomatic and responded to basic supportive therapy, and that's all.
And Dr. Sanjaya, in terms of in Australia, specifically in Canberra, how do we use the sotrovimab antibody as a treatment for Omicron, and how does this perform against sotrovimab being used in Delta patients?
So we've got two, I guess, types of interventions for COVID in Australia. We've got those interventions for the pre-hospital patients and the hospitalized patients. So monoclonal antibodies, they're very purified forms of antibodies, which we are using pretty much to give an instantaneous boost of antibodies to someone with COVID. So as we all know, with vaccination, it takes about 2 weeks to mount an immune response. We're providing instant gratification here by giving monoclonal antibodies, and there are lots of commercial products available. Sotrovimab is one of them, and there's one that President Trump got. The brand name was Regeneron. It's a combination of two antibodies, casirivimab and imdevimab. So we've got both of those in Australia, and imdevimab has even been shown to have some role to play in post-exposure prophylaxis as well. But what we found with Omicron is that because it's got so many mutations, 72 mutations and a whole lot around the spike protein, is that it can evade even these monoclonal antibodies. So the one that President Trump got, the casirivimab imdevimab, it's pretty much useless against Omicron. So we can't use it here in Australia during this outbreak. But the sotrovimab, thankfully, even though it's not as effective as compared to Delta in studies, it still does work. So we are offering it to patients, and the patients we're offering it to are, going by the studies, older patients or patients with a risk factor for severe COVID, so obesity, diabetes, immunosuppression, chronic lung disease, all those sorts of things. People who've got mild COVID infection within the first 5 days of their disease. So that's the setting where we're offering it. And we did that during Delta, and we've done that again through Omicron. As Dr. Neeraj says, we will have to sit down and just look at our data when we've got some time and see how much of a difference it made. I think just using the naked eyeball test, it seems to have made a difference. Most of those patients haven't ended up in hospital. If they do, and of course now we've got these new oral antivirals, like Dr. Neeraj mentioned molnupiravir, that's come to here in Canberra, and there's the Pfizer medication called Paxlovid, which has also come to Canberra. They may also have a similar role to play like sotrovimab, people early in their disease, mild disease with risk factors, so not hospitalized. If people do get to hospital, as Dr. Neeraj said, good just supportive care, oxygen is very important, and a lot of people pick up with that. Steroids was the first drug in a randomized controlled trial to be shown to make a difference in terms of reducing mortality from people who are really sick in hospital with COVID. So that's definitely the backbone of our therapy. But as per various guidelines, we also give people remdesivir and an anti-inflammatory called baricitinib. So that combination, they're the sort of triple therapy we will give unless someone has contraindications. They can't have one or two of those therapies because of their kidneys or their liver, etc. And again, as Dr. Neeraj says, remdesivir in trials, it didn't save lives the way that corticosteroids did, like dexamethasone did. It does seem to have some impact, and it seems to be generally harmless as well in people we've given it to. So that's why it's part of this triple therapy, this cocktail we give to patients.
Okay, thank you so much for the answer.
No, Dr. Sanjay, just one more thing, just as a part of this discussion. Yeah. So remdesivir is not that harmless as it is being touted, because we had patients who developed severe bradycardia after institution of this particular drug. I know people may argue, okay, it could be because of COVID-19, but this was our observation that those patients, especially the elderly ones who had some underlying problem, they were more prone to developing bradycardia once remdesivir was started. So, so these are the things which actually never got published, and this never came in public domain in that way. So if you analyze your data, I will say you just go through that particular thing. What were the different side effects which these patients had? Invariably, they had deranged liver function test. So again, COVID also caused deranged liver function test, but this is something which we observed more frequently in those who were instituted on remdesivir. So that's what I'm saying. The advantage in real clinical practice, we hardly encountered any advantage of this particular drug. At least in my setting, I can talk about, not about the other settings. And that's why these drugs should not be taken as a panacea for COVID-19, because in most of our cases, we never used all these fancy drugs, and still we were able to save those patients. It's not that we did any worse than what the rest of the world has been doing. And that has been possible because of the good supportive care which these patients require. So at the moment, if you ask me, we don't have any up to mark antiviral that can be used in every set of patients. And one more fear which most of us have, those who have comorbidities, they will land up in problem. That is, again, I will say it's a misconception among majority of people. Even among those who have comorbidities, those who are vulnerable, those requiring hospitalization was not more than 10 to 15%. In other words, 75 to 80% of those vulnerable people will do without any specific treatment. So again, identifying for the development of complications. That is the key to saving this patient. This is what we have learned over the last 2 years. And of course, we are waiting for that miracle drug to come, but all the available option at the moment, I will say it's more of a research-oriented treatment options and something which cannot be generalized for all people at the moment.
Yeah. No, and I think you make an important point is the research data might be, the trials might be very good and carried out appropriately, etc. But nothing will beat the real life data of treating thousands and thousands of patients. And of course, the problem is we're also busy treating the patients that we haven't had time to sit down and publish the data, which is something that will happen soon, I think, when this next wave comes down. And as you say, those sorts of patterns will become more apparent and will guide treatment in the future.
Okay, and treatments, we're still needing more data, but what we have been familiar as a society is with public health and social measures in the last couple of years. But this time around, at least in Australia, things are a little bit different in the sense that we don't have any lockdowns. There is no border restrictions. In your opinion, Dr. Sanjaya, do you think this should be put in place?
Yeah, well, I think right now we've got so much COVID in Australia. I think other countries should be scared of us rather than us be scared of people coming from other countries. I mean, we're the hotspot for COVID. We've gone from, when was it, in the last couple of months, from about 200,000 cases nationally to almost 3 million confirmed cases. And the reality is, of those confirmed cases, there could be a lot more. There's a group from the US who was saying that when you're with Omicron, the number of cases you might be seeing may only be 15 to 20% of what really is there. So in Australia, we might have actually had 5, 6, 7 million cases or more of mainly Omicron, but of COVID. So there's been a lot of it here. And I think the rule books really got thrown out to some extent with Omicron because of how infectious it is. A Japanese researcher said that it was about 4.2 times more transmissible than Delta in its early stages. Some Danish researchers found that it was over 3 times, it had 3 times a higher basic reproduction number, that R0 we keep hearing about, than Delta. So it just shows how infectious Omicron is. Because Delta was pretty infectious to begin with, and it changed Australia's whole pathway from being COVID zero to learning to live with COVID. And we therefore have to learn to live with COVID. And at this moment, I think restricting people from coming from overseas it doesn't really make much sense to me. Restricting people from traveling from affected states, Queensland, Victoria, the ACT, South Australia, it also seems rather pointless because it's everywhere at the moment. In terms of lockdowns did have their place, and they're still controversial. There's data supporting the role of lockdowns in reducing outbreaks and bringing them under control more quickly. And there's also other data saying they don't make such a difference, or the harms arising from lockdowns outweigh the benefits. But one salient thing about lockdowns, a paper I saw recently, was that really the benefit you get from lockdowns is probably in that first 4 weeks of the lockdown, when people are compliant with the lockdown. Beyond that, they start to lose interest and start to not be compliant. So even though you're officially in a lockdown, no one's actually following it. And that's why you might see things get out of control. And if you look at Victoria's lockdown around September last year, we saw around the grand final time for the football, there were all these parties and breaches. People were fed up. I mean, as you know, Melbourne is the most lockdown city in the world in terms of number of days it's been in lockdown, although not consecutively. And that is the problem we have moving forward with lockdowns. That doesn't mean we shouldn't have other restrictions in place. Mask wearing, particularly when we can't safely socially distance, using QR codes so that we at least know if we've been exposed to someone with COVID and we should get tested. Those sorts of measures, and of course, rapid antigen tests, having access to them so we can test ourselves if we think it's necessary. Those things shouldn't be forgotten. And even before Omicron came, I was always very concerned with all the restrictions being lifted around Christmas time. I still wanted, yes, sure, I was happy lockdowns were being lifted and that people were going to gather with their families and friends for Christmas celebrations. But those other COVID-safe measures, which really don't impact on us very much, QR codes, using masks if we can't physically distance safely, using rapid antigen tests before a gathering if you're high risk, those things should continue and will need to continue for a while. With pandemic flu in 1918, everyone remembers the horrible 1918 to 1919 period. But even in, I can't remember if it was 1920 or 1921, there was another wave, which was quite serious and killed quite a few people, but it didn't really get reported because everyone was fed up. Everyone was over it. So they just dealt with it. So COVID can still cause some problems moving forward. Hopefully it won't, but it still can. So we have to think about COVID-safe measures, but balancing that with trying to live a normal life.
Great, thank you. And I'd like to direct one of the audience's question to Dr. Neeraj. Someone has asked if the Omicron variant will cause any danger to pregnant women and the baby.
So again, it's too early to say, but based on the previous evidence which we have over last 2 years, and in our center, of course, we have a numerous pregnant lady admitted with us who delivered healthy baby without having any problem whatsoever. So over last 2 years, we have not seen any patient, pregnant lady delivering a baby who we found was compromised because of her infection of COVID-19. And in fact, whatever data we had, in fact, whatever test we did on them, whether it was positivity test for an RT-PCR and all, even we found that most of them were not even positive. So it's important. Of course, we have to keep our surveillance up regarding all these aspects. But in our experience over last 2 years, COVID-19 have not played any significant pose any significant problem to these pregnant ladies or the child born to them so far. So this is what we expect from Omicron as well. Of course, the care provided to them may get affected because of their positive state, because all the healthcare centers may not be equipped to deal with such patients. So from that angle, of course, that can always affect the support they have got. But overall outcome, because of COVID-19 infection as per se, we have not seen much of a difference.
Okay, and I was just one last question. Just wondering if you can comment about the cultural differences on how we approach the pandemic. We'll start with Dr. Neeraj and then we'll finish off with Dr. Sanjaya.
So again, if we talk about India, India is such a large country with such a huge population that you can say there are multiple countries within our own country, a single country. So when somebody talk about, okay, if you have, say, when is a peak coming in our country? So it's really difficult to say, because what we have observed that different part of countries have peak at different time. So just finding out when will peak come in the country is really difficult. So here in Delhi, now the peak has passed, but some part in the countries are still seeing high number of cases. So this boils down to the size of the country, the culture of the country, the way the people deal with the country. So all those places which are connected with international travels, the hubs, whether it's Delhi, Mumbai. So these are the centers which will see peak of cases much earlier as compared to rest of the countries. And of course, these centers will again see a decline in cases much faster than the other part of the country because of the measures which we have in place or the healthcare infrastructure we have in place. So the cultural difference, the size of the country, the type of population, the developed and because within the country also you have developed part of the country, developing part of the country, and some which are relatively, I will say, they have limited resources with them. So these all factors do play a role, and that's going to affect how the pandemic goes about in the country. And we have seen that difference in our country as well. And I'm sure this is something which happens with other bigger countries. Of course, if a country is very small, you can put down lockdown, you can restrict movement of people. But in a country like India, that's not possible. We cannot put country in lockdown for a prolonged period. So you talked about lockdown. So yes, during the first wave, lockdown was very important because nobody knew about this virus. No, even the healthcare professionals were not equipped or trained for handling such a large pandemic. So at that time, that gave us a time to prepare ourselves to deal with this thing. So in that way, of course, lockdown did help. But again, in a big country like India, it cannot be a prolonged lockdown. And I'm sure none of the country can actually afford prolonged lockdown. And this is something which we have learned over time. So this is what I have to say.
Thank you. And what about Dr. Sanjaya? Any comments on how Australians has dealt with the pandemic and whether it's different to what Dr. Neeraj has mentioned?
Yeah, I think, look, Australia is a different country. Australia is a smaller population and it's a rich country. So we are a rich country. So we had, I've forgotten the name of it. One of you can probably tell me the COVID payment. What was it called again? What was the COVID payment called? Anyway, Dr. Neeraj, people in Australia, if they didn't work because of lockdowns, the government would pay them to stay at home from their business. And there were some people who were getting paid more by the government to stay at home than they were getting paid when they went to work. So what was it called? Job something. Oh, terrible. It was a
JobKeeper.
JobKeeper. Thank you. Thank you. JobKeeper. So Australia had the money to do that. We spent billions, and that did help with the lockdowns and maintaining compliance with the lockdowns, because in certain developing countries, people need to work to survive, and they can't afford to stay at home because of potentially a smaller risk, as they perceive it, of getting sick with an infection. So we were able to do that in Australia. But of course, being a liberal democracy as well, we've got people with all sorts of views. We have a government where people can question the government, where the media can question the government. So we have seen more and more groups come out over time, and we've seen the protests at Parliament over the last week, where people are questioning the government's decision about vaccines, lockdowns, mandates for various reasons. And that has happened here, but of course it's happened to a greater extent in places like the United States. And what's been really interesting about the United States, which hasn't been an issue here, is that the COVID behaviors have been according to partisan party politics. So a study came out recently, and I think I've got this right, showing that the most worried people about COVID who were surveyed were young Democrats who were fully vaccinated and boosted, who had a really low chance of getting sick with COVID. And the people least worried about COVID were Republicans who were older and were more likely to have health problems, which put them at higher risk of getting COVID. So all those issues become a problem in a liberal democracy where people feel that they can openly protest against the government, whereas in some other countries that may not be the case. If the government says you're doing this, people will do it because they're scared of the consequences if they don't. But yeah, I think just the way different countries, both within the developed country spectrum and developing countries, have responded to COVID's been absolutely fascinating. And you've got a place like Cuba, which is well known for developing its own vaccines at the Finlay Institute. They've already they've developed their own vaccines. They were the first ones to start vaccinating very young children aged over the age of 2, and they're doing their own thing. So it is extraordinary how different people have responded to COVID.
Yeah, that's interesting. I never knew that it was such a diverse response around the world. Okay, because of time, we'll have to wrap up today, but I just want to thank both of our esteemed speakers so much for making the time to really help us understand what the Omicron variant is all about and the different ways that we've been dealing with both in India and in Australia. So thank you, Sanjaya, and thank you, Neeraj. Thank you for your time tonight. And thanks to our audience as well for joining us. And on behalf of the students, live attendees, and those watching the recording post-webinar, I'm sure that they will enjoy this great discussion that we have tonight. Now, for anyone wishing to know more about our program, I would encourage you to visit our website, and you can do so by having a look at this link. And whilst you might be jotting down some information, I will also invite you to answer our poll. This just gives us a better idea of what we can do to improve from our end. Thank you. Okay. And if you have any questions or if you wish to volunteer, please feel free to email us at international.health@anu.edu.au. And yeah, get in contact with us. We'll be happy to help out and address any issues that you might have. And that's all from us tonight. Once again, thank you so much to Dr. Sanjaya and Dr. Neeraj for making time out of your busy schedules. I'm sure that we will, including people who are rewatching this, will enjoy the discussion very much. Thank you.
Thanks
Thank
to
you.
both of you again.
Oh, no, thank you for having us.